So thanks a lot, first of all, for having me to talk about the development of Givinostat in Duchenne, a work that we have been doing in the last 6 years. So I'm Paolo Bettica, I'm heading the clinical R&D at Italfarmaco. Italfarmaco is a medium-sized pharma company that actually is 80 years old. And the headquarters are in Italy, but actually we are present in many different countries, including the US. Part of our interest in R&D has always been in epigenetic control, and in particular on histone deacetylase inhibitors, and Givinostat is our front runner. So this is a brief description of what we have done so far with Givinostat. So Givinostat is a potent histone deacetylase inhibitor that we are currently developing for 2 indications, one being Duchenne muscular dystrophy and the other one being polycythemia vera. In now more than 10 years of work with this molecule, we have now shown that it has anti-inflammatory effects, it has anti-fibrotic effect and also pro-regenerative effect, and as you will see in the next few slides, we believe that that is very crucial for Duchenne. One of the advantages of having worked extensively with this compound is that we now have quite a good knowledge of what this compound does. So we have conducted different clinical trials now involving more than 450 subjects that have been treated with Givinostat. Many of them have actually been treated, well, most of them have been treated for 6 months and many of them for more than 12 months. And of these, actually 51 are either children or adolescent, because not only we are working in Duchenne muscular dystrophy, but we have worked in juvenile idiopathic arthritis. So as a result, we have a significant number of children and adolescents exposed to Givinostat. With regard to Duchenne, the 20 children that have been enrolled in the study 43, which I am going to describe in a moment, are now in the second extension, so they have been treated for up to 3 years. What does give us? Does that give us is actually the knowledge of what are the limitations, if you want, of the drug and how to use it. So we know that Givinostat is actually well tolerated, but the 2 frequent adverse events that you can see with Givinostat are, one, a platelet reduction. This is a laboratory finding, so it has never translated into any symptom of platelet reduction. It is what we know it is a pharmacological effect of the HDAC inhibitor, and in fact what it does, it actually freezes the maturation of platelets. So as a result of that, what happens is that you see this effect quite rapidly when you have a dose which is too high. And the most important thing is that the platelet go back to normal after 2 or 3 weeks when you stop taking the drug. The other adverse events, which are relatively frequent, are nausea, so GI side effects, nausea, vomiting, but mainly diarrhea. And this is actually a transient effect. What we have been told by the children in the Duchenne study is that stools are more frequent, but that they can adjust to that with no problem. Oops. How did it work? Yeah. So let me try and summarize how we believe Givinostat works. So this is, and I'll do that with the following 3 cartoons. So this is a cartoon that you have seen probably many other times. So a section of the muscle, and a representation of where dystrophin stays in the muscle fibers. And as you have heard many times already, dystrophin is actually working as a shock absorber in the muscle. So we all actually have repetitive muscle injury in our muscle, and what happens in the muscle that has fully working dystrophin is that the injured muscle is first attacked by the inflammation cells. They remove the debris, and that actually stimulates the regeneration of new muscle fibers, And as a result of this process, you actually have a restoration of the muscle as it was before. What happens when dystrophin is not present is actually a different process. So you have inflammation, it usually stays for longer than needed. And instead of actually replacing the lost fibers with new fibers, you get increasing amount of fat and fibrosis. So what we believe Givinostat can do is actually, obviously it will not restore the dystrophin, but what we hope it will do is actually rebalance the process towards the more natural restoration of normal muscle. Okay, this actually has been tested in the preclinical model, so in the MDX mouse. We have published this 3 years ago. And as you can see, there is a significant dose-dependent increase in muscle fibers. There is a significant dose-dependent decrease in fibrosis, and actually this translates into a better, if it comes out, performance on the treadmill. So these preclinical data have been actually the basis for the study 43, which I'm going to describe now. In essence, what we wanted to prove was that what we have observed in the animal at the histology of the muscle could occur also in young children with Duchenne. So an increase in muscle, a reduction in fibrosis, a reduction in fatty necrosis and of inflammation. So this is a study that we started. It's a bit complex, but I spent more time to describe it. So it was an open label study. Initially it was a 2-part study, then we have actually extended the study for 2 more times. We enrolled 20 ambulant children. They were 7 to less than 11 years of age. They had DMD proven by genetic test, and obviously we accepted every type of genetic defect. And they had been all on steroids for at least 6 months. At the end, actually, all except 2 had been on steroids for more than 2 years, and the other 2 have been on steroids for more than 1 year. So the first part was, in essence, the objective of part 1 was to identify which was the best dose to use in the following part, in part 2. So we started with 25 milligram BID, which was well tolerated. We went up to 50 milligram BID, and at this dose, actually, 2 children met a predefined stopping criterion on platelet reduction. So that dose was declared not tolerated. And then we went down to 37.5 milligram BID, which was did not have any problem. So that was decided, that was chosen as a dose to move forward in part 2. And so part 2 was actually a 1-year treatment at this dose. And after a while, using the 37.5 milligram BID, we noted that some children actually had still a reduction of platelets below the lower limit of normal, never reaching the stopping criteria, but still below the lower limit of normal. So we decided that those actually should reduce their dose to 25 milligram BID. And then we reached the end of part 2, which was in July 2014, and we looked at all the results, the primary endpoint being the change in histology. And then, as I said, we extended the study. We are now in the 3rd year of treatment, and still 18 kids are in the study. The 1 kid actually decided to stop because he could not tolerate running a clinical trial anymore. So let me point to one thing, which is that obviously the age when we started was between 7 and 10.7 years of age. By now, well actually by July 2015, so 1 year ago now, obviously the kids were 9.3 to 12.9 years old, so they were becoming older. Okay, so what did we see? As I said, the primary endpoint was histology. So we compared the histology after 1 year of treatment to the histology that we observed at baseline. The baseline biopsies, we have 4 examples of these are represented on the top panel. And as you can see, there is a lot of white and gray, which is in essence fat and fibrosis. When you look at the bottom picture, you see much less of white and much more of actually pink, and pink is actually muscle. So obviously you can read that with an imaging analysis tool, and this is what you get. So we were measuring muscle fiber area fraction, so the amount of the fraction of the muscle biopsy which is occupied by muscle, the total fibrosis, which is a percentage of your biopsy which is occupied by fibrosis, by scar, and same was true for total necrosis and fatty replacement. And as you can see, let's start from the left. On the left you see the muscle fiber area fraction. Each column is one child, and the black column on the right is actually the mean for the group. Each child actually has an increase in muscle area fraction, and on average this increase is of 29%. The reduction in total fibrosis is in essence specular, so you have a reduction in all children with an average of 27%, and also you see a reduction in total necrosis and total fatty replacement, and all these changes were actually highly significant. Obviously, a biopsy is a tiny piece of muscle, so we wanted to have a confirmation that this could be seen also, if you want, macroscopically, taking a big picture of your muscle with an MRI. As you recall, this was a single-arm study, so there was not an internal control. So we actually tried quite desperately actually to find an external control that could be used. And we finally found it. It was actually very close to us in Milan. This was if you want, preparation part of the mesangioblast transplantation study that was done by COSU some time ago. And we could actually find a cohort of children, 13 of them actually, that were comparable to the one that we have used in study 43. So they were all on steroids, they had a similar age, and they had a baseline, a 6-mean walk distance of at least 300 meters. And you see the summary of them in this table. So as you can see, study 43, the age was 8.3 years, and it was 8.8 in the cohort, the control cohort, which was not different. The 6-mean walk distance was slightly worse in the control group. But what actually was very important is that the MRI was actually superimposable between the two groups. Now, one comment regarding the MRI. When we started the study, the quantitative MRI was not developed as much as it is now. So we have actually used the qualitative score, which was a Mercury score, which has been published some time ago. And let me spend 1 second in explaining this slide. So the score is actually going from 0 to 5. So 0 is a normal muscle MRI, and 5 is actually a full replacement of the muscle by fat and fibrosis. And what you see here is actually the change in the score between baseline and 2 years of treatment. Green is actually our kids treated with Givinostat in our study, and yellow is a control group. And as you can see, in all muscle that we looked at, which were the gluteus, or the thigh muscle, and the leg muscle, the green column is actually much shorter than the yellow one, showing that actually the change in the MRI score was actually much smaller after Givinostat compared to the control group. So obviously the study was small, it was just 20 kids, but we obviously looked at function. We looked at function of the lower limbs first, And actually looking at the 6-minute walk test, we did not, and comparing it to the natural history data from the Italian cohort, we did not see big differences. And obviously one key question could be, well, maybe the issue was that we started the study too late, that Givinostat could not really work at this stage of the disease. And one suggestion in support of that was actually coming from the biopsy results, because if we look at the baseline biopsies, actually 50% of the muscle was already gone, despite actually being the biceps, not the quadriceps. So, and actually in support of this potential interpretation is also the other function data that we actually measure. So we measure the respiratory function and the upper limb function. And the reason why I stressed the age of the kids at the beginning and then after 2 years is actually related to this study that was recently published, which is in essence showing that the kids between 8 to 10 years of age already start losing respiratory function. And what we see with Givinostat is that actually the percentage predicted vital capacity and path is actually stable after 2 years. We also looked at the upper limb function, and as you know, the function is initially lost at the shoulder, so that we concentrated on the shoulder function. And as you can see, this is a graph taken from a recent publication by Pane. At the age of 10 approximately, kids start losing the function of the shoulder as measured by the PUL. And also here, regardless of the age of the kids when they started the study, there is actually maintenance of the function. So if we summarize these results, we believe that Givinostat is actually well tolerated at the selected dose that were used in the study with Duchenne kids that were 7 to less than 11 at baseline. We have shown a highly significant histological improvement, so an increase in muscle fibers and a reduction in necrosis, fatty replacement, and fibrosis. We have actually shown that this could be confirmed also at the macroscopic level using MRI. And as I have just shown, we have shown stability in pulmonary and upper limb function. And we believe that actually this means that Givinostat is able to slow down the progression of the muscle damage. So what is next? We are launching now, we have just gotten the clearance from the FDA for the IND, a new study, which is a study which has the objective to demonstrate that Givinostat can preserve the muscle mass and slow down the disease progression. And we plan to do so by making 2 evaluations. On one hand, MRI, so a morphological assessment, and on the other hand, the function test. This will be a double-blind placebo-controlled study. The randomization will be uneven, so the chance of getting Givinostat will be 2 to 1. And the total number of children that we would like to enroll is actually 220. So the children must be ambulant, D&D boys. Their age should be 6 and older. They need to be on stable corticosteroids for at least 6 months prior to the start of treatment, and they need to be able to perform a 4-stair climb in no more than 8 seconds. And the treatment duration is actually 18 months. So let me remind you, I didn't mention that before, but Givinostat, obviously or placebo, given that it is a placebo-controlled study, is an oral suspension. So you will receive a bottle with an oral suspension that needs to be taken twice a day. The visit will be in total 15. In the first trimester, it is relatively frequent for the reason which I mentioned before, which is that we need to optimize the dose by looking at the platelet counts. And so you will be asked to actually do that measurement every 1 or 2 weeks. And then after that is actually every 3 weeks. So there are a number of assessments that will be done, obviously safety lab, ECG, muscle test will be done every 3 months, and they are the standard, so 6-minute walk test, North Star, the time function test, and the strength test. The thigh MRI will be done at baseline, months 12 and months 18. And then the pulmonary function test and quality of life will be done at baseline, months 12 and months 18. And then beginning at the end, you will also have a cognitive evaluation and a cardiac echo. So where are we now? Well, the study will be conducted half and half between US and Europe. And so we plan to open 20 sites in the United States and 20 sites between Canada and Europe. The IND, as I said, has been cleared, so we are now ready to submit the protocol to the IRBs and get the contract started. And so if everything goes well, then we plan to start recruitment in October 2016. And then now that we have had the clearance for the IND, we will be posting all the summary of the study on clinicaltrials.gov. And last but not least, let me thank all the people that have been involved and all the different foundations that have actually helped us. Thank you.